Assalamualaikum and a very good day I bid to everyone who are watching our presentation. I am ARINA NATASHA and my other group mates are Anis, NADHIRAH, AZIM HILMAN, Muhammad IQBAL and also Muhammad IRFAN will present about a disease called Ramsay syndrome. So throughout this presentation, we will present to you guys the introduction about the disease, pathophysiology of the disease, clinical manifestation, management, and also a sample of case report regarding this disease. So before we are going deeper into this topic, I want you guys to know a little bit background about this disease. James Ramsay is an American neurologist, as you can see in the picture I put in the slide, is the first one who discovered Ramsay syndrome in 1907. There are also several names for Ramsay syndrome such as herpes zoster oticus, geniculate neuralgia, or nervous intermediate neuralgia. It is a rare neurological disease that may affect approximately 5 out of 100,000 population. Ramsay syndrome is more common in females than males, but the reason behind this still remain unknown. It is mainly seen in adults and rarely in children. Ramsay syndrome is the second most common cause of non-traumatic peripheral facial paralysis. The most common one is Bell palsy. Ramsay syndrome can be defined as acute peripheral facial neuropathy associated with erythematous vesicular rash of the skin of the ear canal, auricle, which is also termed as herpes zoster oticus, and or mucous membrane of the oropharynx, meaning that the patient can still be diagnosed with Ramsay syndrome even though he or she presented with only one area with the erythematous vesicular rashes. Next, the cause or the culprit for Ramsay syndrome is the varicella zoster virus. It is the same virus that can cause chickenpox that we usually get during our childhood. So after being affected, the varicella zoster virus will remain dormant in the neurons of the cranial nerve, the dorsal root ganglion, and autonomic ganglia. This is what we call as latent period. In Ramsay syndrome, the varicella zoster virus is reactivated in the geniculate ganglion of cranial nerve 7, which is the facial nerve, and eventually spread. This explains why and how the virus can cause facial palsy. And in this slide, I already put and highlighted the geniculate ganglion for you guys to have a better visualization about my explanation just now.
Let's move on to pathophysiology section. For the histopathology, figure 1 shows horizontal section just below the geniculate ganglion, showing the internal auditory canal and the horizontal segment of facial nerve. A indicates posterior half of the facial nerve is atrophied, while B indicates superior vestibular nerve is atrophied. Figure 2 shows high magnification of the facial nerve, showing degeneration of the posterior half of the nerve. After that, the differential diagnosis. The first one is Bell's palsy, which is the most common cause of sudden onset, non-traumatic facial palsy, and can be differentiated from RHS by the absence of severe otalgia and the absence of vesicles and involvement of other cranial nerves. The next one is acoustic neuroma. This can be excluded from differential diagnosis by doing MRI scan. The other differential diagnoses are postoperatic neuralgia, temporomandibular disorder, and trigeminal neuralgia. Lastly, the risk factors. The patient might previously having chickenpox, may being older than 60 years because this disease is rarely occurs in children, and having a weak or compromised immune system.
These are the clinical manifestations of Ramsay-Hunt syndrome. In patients with Ramsay-Hunt syndrome, a careful history must be obtained. Patients usually presented with paroxysmal pain deep within the ear. The pain often radiates outward into the pinna of the ear and may be associated with a more constant, diffuse, and dull background pain. The onset of pain usually precedes the rash by several hours and even days. There are two main signs and symptoms of Ramsay-Hunt syndromes. First one is a painful red rash with fluid-filled blisters on, in, and around one ear. And the second one is the facial weakness or paralysis on the same side as the affected ears. Let's discuss more on the vesicular rash of the ear or mouth, which occur as many as 80% of Ramsay-Hunt syndrome cases. The locations of the accompanying rash varies from patient to patient, as does the area innervated by the nervus intermedius. It may include the following: anterior two-thirds of the tongue, soft palate, external auditory canal, and pinna of the ear. These are the other clinical manifestations in Ramsay-Hunt syndrome. The first one is vertigo and ipsilateral hearing loss. Hearing impairment is usually more severe in patients with vertigo than in those without vertigo. What is vertigo? Vertigo is a symptom rather than a condition itself. It's the sensation that you or the environment around you is moving or spinning. This feeling may be barely noticeable, or it may be so severe that you'll find it difficult to keep your balance and do everyday tasks. The second one is tinnitus, which is also known as the ringing in the ear. Next one is otalgia, and the last but not least is cellulitis, which may result from secondary infections from blisters of the skin of the ear canal and auricle. What can be the complications of Ramsay-Hunt syndrome? For most people, the hearing loss and facial paralysis associated with Ramsay-Hunt syndrome is temporary. However, it can become permanent if left untreated. Facial weaknesses will then lead to eye damage, as it results from the difficulty to close the eyelids that will lead to damaged cornea. Postherpetic neuralgia is the most common complications of shingles. The condition affects nerve fibers and skin, causing burning pain that lasts long after the rash and blisters of shingles disappear.
Now let's move on to management, where I will explain about the treatment's goal, the medication, the lifestyle and home remedies, and lastly about the prevention. Treatment goals for Ramsay-Hunt syndrome is first to minimize the disability, and second is to relieve the symptom, especially pain. Okay, for medication, we have antiviral, corticosteroid, anti-anxiety medications, and lastly the pain reliever. Antiviral drugs. Medications like acyclovir often help combat the chickenpox virus. Next is the corticosteroid. Corticosteroid, like a short regimen of high-dose prednisone, appears to boost the effect of antiviral drugs in the Ramsay-Hunt syndrome. Then, the anti-anxiety medication, like diazepam, can actually relieve the vertigo. Lastly, the pain reliever. The pain associated with the Ramsay-Hunt syndrome can sometimes be very severe. Thus, prescription pain medication may be needed. Next, I will talk about the lifestyle and home remedies, which can actually reduce the discomfort of Ramsay-Hunt syndrome. First, we must keep the area affected by the rash clean. Second, to ease the pain, we can apply cool, wet compression to the rash. Lastly, we can use an eye drop or eye patch, since throughout the day, the eye of the patient for the Ramsay-Hunt syndrome can become very dry. Okay, lastly, I will talk about the prevention. As we know, there's a vaccine for this disease. First, for the children is the varicella vaccine. For the adult is the Zostavac. Okay. For the children, the varicella vaccine can reduce the chances of getting chickenpox, from which the syndrome comes. However, once a person gets chickenpox, the person is susceptible to reactivation of the virus and thus can develop the Ramsay-Hunt syndrome. Fortunately, there is another vaccine, which is the Zostavax, which is very helpful in preventing viral reactivation. Consequently, the Ramsay-Hunt syndrome can be either prevented or the symptom can be reduced if the vaccine is being administered. And usually, this vaccine is given to individuals that have had chickenpox as children and now age 60 or older, since the risk factor for this disease is 60 or older in age.
So next we continue with case report. This is the case report. A case report regarding a case of Ramsay-Hunt syndrome diagnosed after kidney transplantation. So the case presentation is a 35-year-old kidney transplant recipient presented to the nephrology outpatient clinic because of left autalgia and periauricular vesicles. He underwent deceased donor kidney transplantation because of hypertensive end-stage renal disease about 2 months before the first symptoms appeared and had been using immunosuppressive medications. He also underwent emergency surgery before we checked the final result of the viral markers, and later we found out that his serum varicella zoster virus immunoglobulin IgG was positive, while IgM was negative. The initial vital signs were stable. In addition to pain and vascular rash around the left ear, and he also complained of numbness of the left half of his face, but neurologic examination revealed no abnormal findings. 2 months after surgery, the recipient was diagnosed with Ramsay-Hunt syndrome and treated with antivirals and steroids. However, after using the antiviral agents for the recommended duration, facial paralysis occurred as a new presentation and he required further treatment. Autalgia and periauricular vesicles improved, but the facial palsy remained. So we continue with investigation of the case report. Routine laboratory tests were conducted and revealed a serum creatinine level of 1.9 mg per deciliter. Estimated glomerular filtration rate was calculated using the modification of diet in renal disease equation, and the value was 48 ml per minute. The serum varicella zoster virus VZV, IgG and IgM was measured, and serum VZV polymerase chain reaction PCR was also performed. However, his symptoms were sufficiently clear to make a diagnosis of Ramsay-Hunt syndrome with or without serologic confirmation of VZV infection. And although the serum VZV IgM was negative, as I stated before, a positive result was also obtained on serum VZV PCR. So in this case, the serum varicella zoster virus IgG is positive, and serum varicella zoster virus PCR are also positive. So etiologic evidence was confirmed. So next we continue with the management or treatment of the case. His regimen included tacrolimus 3 mg, mycophenolic acid 720 mg twice daily, and a steroid or prednisolone 20 mg once daily. The Ramsay-Hunt syndrome is treated with steroids to reduce the inflammation, and a starting dose of 50 to 60 mg of prednisolone is commonly used along with an antiviral agent to suppress the virus replication, which is regarding to the VZV virus. So acyclovir is believed to reduce nerve damage, so its clinical usefulness is widely accepted. And also there's adjunctive therapies. Adjunctive mean addition therapies such as facial massage and acupuncture can also be useful, but there have been no systematic studies to evaluate the effectiveness of these treatments.
This slide shows our reference that's been used for our slide. Thank you for listening and have a nice day.